Good afternoon, everyone. We're extremely fortunate and grateful to have with us a very prominent clinician investigator, Dr. Nancy Klimas. Dr. Klimas is professor of medicine at the Department of Clinical Immunology in the College of Osteopathic Medicine at Nova Southeastern University, where she's also director of the Institute for Neuro-Immune Medicine. She's also affiliated with the Miami VA Medical Center and University of Miami School of Medicine. Dr. Klimas has more than 30 years of professional experience and has achieved international recognition for her research and clinical efforts in multi-symptom disorders, myalgic encephalomyelitis, chronic fatigue syndrome, Gulf War illness, fibromyalgia, and other neuroimmune disorders. She's a member of the VA Research Advisory Committee for Gulf War illness and the NIH committees, as well as the Institute of Medicine review panels on myalgic encephalomyelitis and chronic fatigue syndrome. Dr. Klimas has advised 3 secretaries of health and human services and has been featured on Good Morning America, in USA Today, and the New York Times. She will be sharing with us a very brief summary of her extensive research insights about the current state and future directions of Gulf War syndrome. Dr. Klimas, thank you.
And thank you. It's so kind of you to invite me to speak with everyone and to be here today. And I'm glad you're recording this because I'm going to want to copy. I think that we should perhaps try to get more Gulf War illness clinical management type talks out there. I think there's a lot of providers that struggle to know what to do because we have failed to give them very much advice on what to do. So do I have control? Because I'm not advancing the slides.
I believe so. Go ahead.
Well, I'm trying. Oops, see.
Because you're sharing, so.
There it goes.
Yes,
that'll work.
You're good. Go ahead.
Yeah, I figured it out. So I am the director of the Institute for Neuro-Immune Medicine. This is a research and clinical institute that umbrellas the VA Miami Environmental Medicine Program, as well as the Nova Southeastern University's integrative medicine and environmental medicine programs, both clinically and as research. I'm focused today on Gulf War illness. This is an illness that has had appalling consequences. In essence, these Gulf War veterans from the 1990-91 conflict, when Kuwait was invaded, and an international group came to their aid, including 800,000 troops from the United States. About a quarter to as many as a third of the Gulf War veterans that were there had so much exposure to so many toxins that they developed a chronic illness called Gulf War illness that they continue to be ill from to this very day, more than 30 years later. There's a nice paper just came out a couple years ago that talked about the position of the healthcare provider that's trying to treat Gulf War illness and how they struggle, that there's challenges, both a lack of knowledge. Thank you for inviting me because I'll try to rectify some of the knowledge gaps. That there's so much diversity within the patient population as to how this illness presents and what's going on, that it really needs a very personalized approach, which makes it actually very well suited to an integrative medicine approach. So I'll keep that in the back of your head. Obviously, we haven't provided you with enough treatment options. There haven't been enough clinical trials, though at the current time, there's more than 28 active clinical trials in clinicaltrials.gov. So that is trying to be rectified. And of course, systemic challenges themselves. A lot of these veterans are ill. They're trying to go through a disability process. They're being assessed for disability based on their comorbid conditions rather than Gulf War illness directly, because we don't have an ICD-10 code for Gulf War illness. And so we're filling out forms. You're filling out these forms of chronic fatigue syndrome and fibromyalgia and so on. And that's a challenge. And there are other systemic challenges for us, systematic challenges. Even our formularies can be difficult because these patients are often treated with a lot of nutraceuticals and things, and we have very few of those on our formulary. So you can see on this slide that Gulf War illness and chronic fatigue syndrome have a lot of overlap, and it's because they're both symptom-based clinical criteria. So there's no underlying single lab test you can draw that says, aha, Gulf War illness or ME/CFS. And you'll see that these are widely overlapping. So that's why many of these veterans are going to hand you an ME/CFS disability form, because we have one in the VA, and we have one for fibromyalgia. And they're probably going to meet the criteria, because you can see that these are widely overlapping symptoms that present, and where they tend to differ tends to be in the lung, which you can imagine because these veterans also had a lot of burn pit and oil well fire exposures, and so they have an increased prevalence of chronic bronchitis and consequences of long-term bronchitis at this point. So like many chronic diseases, when you see something that you don't understand, you have to stop and think, okay, well, what do we know? And it starts with, are some people at risk? Is there a genetic predisposition? And then if so, and you can say this with, let's take a different illness altogether, like let's say Reiter syndrome or ankylosing spondylitis, where they'll absolutely have this HLA-B27 subtype, but they may never in their whole lifetime run across the infection that triggered the illness that became that autoimmune disease. And that's really mapped out, right? We all understand that there are people have the genetic predispositions for some illness and they never get it because they never came across their triggers. So you have to ask in an illness like Gulf War illness, where 1/3 of people are sick, not 100%, and they nearly all had massive exposure. Was there a genetic predisposition? Was something that made about 1/3 of the general population, more likely to suffer a toxic injury and never recover than the rest of the population? And I think we actually have that sorted out now. That's my next slide. And then the triggering event or infection, let's take long COVID as an example. The infection, they might have a genetic predisposition that makes them more vulnerable for that. We don't know yet. But then they got COVID, an acute infection, and now they have this long-term illness, long COVID. And so we're thinking Gulf War illness the same way. The triggering event in this case was toxic exposures in war. And so one of the interesting things about that is that the animal models of Gulf War, you have to put the toxic exposures into the animal model and a lot of stress, physical stress hormones, specifically cortisol. You have to spike the cortisol in the animal at the time of the exposure to create the brain event that creates a chronic inflammatory brain for essentially, in a human model, decades thereafter. So sometimes it's events that you had to have the exposures and have these cortisol elevations that you wouldn't find unlikely in a war zone. Finally, you've got the patient you're looking at. 30+ years later, you've got someone who's sick, and you're trying to untangle this mess by sorting out what the mediators of their chronic illness might be. And in Gulf War illness, we know the mediators are, you find there's immune problems, there's endocrine problems, sleep disorders, viral reactivation, and I left this one off, and it's important, mitochondrial or bioenergetic problems. And then psychosocial, I put that in because an awful lot of veterans who've ever been in a war zone have an overlay of PTSD, or they have traumatic brain injury. And there's this theory with Gulf War illness that a two-hit theory, that your brain is more vulnerable if prior to this exposure to the Gulf War conditions, the toxins, if you'd had, say, a concussive injury. And it turns out that an awful lot of veterans in high school were football players, or that they rolled a car, or that something happened before they ever signed up for active duty. So a lot of people have a first hit phenomena. An easy thing to ascertain actually in your physical, when you assess your patient, is how many times in your life have you been knocked unconscious? That's a great screening question. You'll get all kinds of answers. But there's the other thing, and I go back to the animal model, that cortisol spike, that in the animals, if we want to make it flare up and get worse, we have another, we pop them with another short course of cortisone. So that means life events are likely to cortisol inspiring, stress hormone inspiring events are likely to kick this up another notch intermittently. So you can imagine why these patients ride this roller coaster. And then the other thing that could hit them again in their lifetime is any other brain injury, be it another traumatic brain injury or an infection like COVID that's neuroinflammatory. Any of these things could potentially be something that kicked up the severity of their illness. Anyway, those are the mediators, and that results in this disease. So what we know about the genetic predisposition is been coming out. Our group mentioned some years back that this PON1, which is a gene responsible for all the detoxification pathways for organophosphates, nerve gas is spelled very badly, and a host of drugs, but also really simple things like when you put gas in your car, it's the detoxification pathway for the fumes that you inhale, or diesel, that type of thing. So PON1 is an important pathway, and it turns out that Gulf War illness vets have a much higher incidence, very much higher incidence of these PON1 mutations when they do the genetic analyses. Haley went one step further in a very, very recent article and was able to associate this PON1 mutation, this polymorphism, and showed it tightly connected to the sarin exposures that these veterans had during the Gulf War. I sort of slipped over that real fast because these veterans, some 250,000 of our 800,000 troops, got a letter from the DOD saying, hey, oh, by the way, you were exposed to sarin when we blew up the munitions depots. There were 50-gallon drums of sarin, and they aerosolized this sarin into the atmosphere, enough so that it popped the chemical detectors that they had all around. Remember, we were worrying about sarin during this war, and there was, for those of you my age anyway, you might remember, and there were chemical exposure detectors everywhere. And so you can actually ask a veteran, did you ever hear the chemical alarms go off? And they'll tell you, oh yeah, we got into our suits 8, 9, 10 times. Or, no, I never heard it. And that's an interesting thing to hear because Haley was able to associate the sarin exposure with Gulf War illness symptoms and this gene and linked it all together. So the triggering event, this perfect storm. The big one was the organophosphates. We had organophosphates, all types of organophosphates, lots of pesticides. Some 15 different types of pesticides were in play in the theater. But there's also this big sarin exposure after the destruction of the munition depots. And the veterans were taking pyridostigmine, bromide, which slows the detoxification of sarin by interfering with the detoxification pathway. So it's another one that could have potentially cranked up the level of the pesticides or the sarin. And they were taking these on a regular basis. They weren't just taking them when this chemical alarms went off. In addition, there was the burn pit exposures and the oil well fires that I mentioned. So I'm going to leap from that to the mediators, because that's really where what you would need to hear when you see a veteran with Gulf War illness and you're trying to sort out what's wrong with them. One of the mediators is the sympathetic parasympathetic imbalance of autonomic dysfunction. And there's a lot of different names for this, a lot of different ways it can present. The most common is something called postural orthostatic tachycardia syndrome, or POTS, which is just someone who, when they stand up, their pulse goes more than 30 beats higher than resting. There's a test you can do where you just lean them on the wall in your room. This is called the NASA lean test, NASA, the astronaut lean test. You lean them on the wall and you take their blood pressure and pulse for 10 minutes leaning on the wall. It's the cheap man's tilt table test, because when you lean on the wall, you're not using as many muscles in your extremities. You don't have as much compression on your veins, and you exaggerate the amount of blood that drops into your lower extremities. So you can do this test yourself in the clinic if you've got 10 minutes, and I know you only have short visits, I'm sorry. But you can also send the patient home with a blood pressure and pulse monitor and have them do some of this at home, to do a resting, a flat in bed, and 10 minutes after you get up, pulse and blood pressure log for you for a week, and get a handle on how much orthostatic challenge can cause an exaggerated tachycardia or a drop in blood pressure. So it's a nice, easy kind of diagnostic. Now, your cardiology group should also have the ability to do tilt table testing, and so that's another much more formal way to do it. So the cut point is 30 and 30. 30 beats of pulse change would be abnormal, or a drop in blood pressure of 30 millimeters or less in either diastolic or systolic would be abnormal. So what do we know about this in Gulf War illness? Well, it happens. And when you do tests at rest and under challenge, you can see decrease in blood flow to the brain. You can see changes in heart rate variability. An awful lot of your veterans now are toting an Apple Watch or some other watch that has a pulse monitor on it. And most of those also have a heart rate variability measure that you can see in the data. So you can ask them to share the data with you and see what's going on. And it's normal for your heart rate to have a lot of variability, and it's abnormal for it to get really, really low. That would be an autonomic dysfunction. So you can see that there's been work in this area. So what does it mean for treatment? Well, it's kind of a neat thing, because this is one of the things you can really help a veteran with when they have a lot of dysautonomia. And remember, when someone has dysautonomia and they're having these rushes of tachycardia, they can present like a panic attack. They can be misdiagnosed as panic, okay, or anxiety. So it's an interesting thing to listen to them and really get their own take on whether or not they really do have anxiety or panic, or is this simply weird times when suddenly their heart is racing and there's no emotional trigger to that. It just happens. And that's a big difference between a panic that tends to have a real trigger and this, which is dysautonomia. Anyway, pipes and pump, if you think about it, it's a pump, the heart, and a bunch of pipes, your vasculature, and it's wired by the autonomic nervous system. So you can do things that help. Remember that you are triggering a tachycardic response or a sympathetic response by having your stretch receptors shrink and send a signal to the brain to ask for more vasoconstriction and to send more blood by vasoconstriction back into the atria. And so if you fill the space, you aren't going to see the stretch receptors sending that signal. That's the easiest thing to do, is to ask people to drink Gatorade-like drinks. I usually try to avoid the colors, the dyes in the drinks, but different ways of expanding using electrolytes, if their blood pressure allows it, to just fill the space. 2 bottles of 12 to 16 ounces of Gatorade, 16 ounces of electrolyte drink a day would give you a volume increase of about a half a liter. And that's enough to fill the space. And very often that's very helpful. The problem is the body gets kind of used to that, and then it starts peeing it back out again, because your kidneys are effective little things. And so sometimes you have to move then and fool the kidneys through using fludrocortisone or Florinef, 0.1 milligrams of Florinef, to retain a little sodium and increase the blood volume that way. If you do that, remember that when you retain sodium, you kick out some potassium. So you have to check the potassium level. They could lose some potassium and become hypokalemic. So I always check potassium a month after I start fludrocortisone. And of course, keep them with that blood pressure cuff to make sure you didn't raise their blood pressure too much when you add volume to these patients. The other thing you can do is regulate the pump. If there's more time between beats to fill, then it's going to fill more and you won't get the stretch receptor thing happening. And so beta blockers. And you can use selective beta blockers. They're very safe and they're not fatiguing. In very low doses will work, like 25 milligrams of atenolol. Or you can use a very low dose of propranolol, like 10 milligrams of propranolol, for different reasons, because sometimes that also reduces some of the adrenergic drive. You can compress the space. Now, the easiest way is using compression hose, but trying to get people in South Florida, particularly men, to wear compression hose is really difficult. But it works, and it avoids another drug. But if you are forced to use another drug, there's a drug called midodrine. I'm sure you're probably familiar with using this in older people who faint when they stand up, because it vasoconstricts the venous, preferentially the venous side, and you get less blood in the legs. By the way, the physical exam for this, when you're standing them up on the wall and you're leaning them on the wall, their legs are going to get mottled and red and blue because there's so much venous engorgement during this event. So you have a nice physical finding to look for when you're doing this. Finally, reconditioning, and I say gentle because these are patients that if you push them too hard, they will crash. And by that, I mean they have an aerobic threshold, and if they push too hard beyond aerobic threshold, they're going to get a lot of oxidative stress, and you're going to see them sick in bed or feeling really lousy for days or even weeks afterwards. So the reconditioning of these patients has to be done very carefully. But in this, you're trying to get more core tone and leg muscle tone. So this is like using core exercises and leg muscle strengthening exercises to treat this. The immune system's a little trickier. What you see in Gulf War illness is that the immune system's overactivated. There's cytokines that are inflammatory. There's C-reactive proteins and that type of thing, not too far out of whack, because this is not an immune complexing disorder normally. When you see immune complexes, I always start worrying about autoimmunity in these patients. But generally, the inflammation is coming from cytokines, from tumor necrosis factor and that type of thing. And it doesn't pick up well in your normal laboratories. They also have poor cytotoxic function, and viruses tend to reactivate, like Epstein-Barr virus. So you can actually look for that. You can measure Epstein-Barr virus serology. So the trick then, when you're looking at the immune system of Gulf War patient, is trying to think of ways to reduce inflammation without reducing their immunity further. That's catch-22. I use omega-3 a lot. It tends to be a very healthy thing. It's good for a lot of things. It's good for their cardiovascular system as well. But omega-3, when you get up to the level that you use when you're treating triglycerides, when you get to 2 capsules twice a day, 2,000 milligrams twice a day, like you do with Lovaza, that is actually TNF inhibiting, and that starts reducing inflammation. We use a lot of something called low-dose naltrexone. I had to get it specially on the formulary at the Miami VA, and I had to go through a lot of hoops to get it there. But this is a very gentle systemic way of reducing inflammation in the brain and the body, but mostly the brain. And I have a slide on it. I'll show you how it works in just a moment. And then other things that reduce inflammation, if they have allergies, deal with that. You know, if you have to send them to allergy clinic, or at least get them to change out their pillows and put their pillows in the dryer once a month and get the mite exposures down and those kinds of things, because anything that drives the immune system into higher levels is going to make them sick. Vaccines, you have to balance the risk-benefit ratio. I've certainly encouraged all of my patients to take the COVID vaccine despite the risks, but I have been pre-medicating them with things that quiet mast cells, and I give them antihistamines for the whole week of the vaccination, and I pre-medicate them with some things that are known to stabilize mast cells. There's an herbal called quercetin that I use, or luteolin, 2 different herbals that are able to quiet mast cell activation. Things to try to deal with the cytotoxic dysfunction and improve antiviral function is a little tricky. I always work up immunoglobulins because I find IgG subclass deficiencies and even true low total IgGs, in which case, again, we can treat these. If need be, we can treat them with replacement antibody. And again, you'd use your immunologist there at the VA to help you with that, or your hematologist. Enhancing cytotoxic function is something we really work a lot on and do a lot of research trying to find things that help. There's a drug, a supplement called inosine or isoprinosine that enhances NK cell function. Mushroom extracts, I'll usually do this by telling people to put that in their diet rather than having them buy expensive extracts. And there's different other supplements that have, like this one called Equilibret, that has herbs that are known to have immune modulatory effects. There are others. It's a long and complicated field, but nothing that's gone through Gulf War illness clinical trials. The antimicrobials, there was a lot of talk early on that Gulf War illness was a mycoplasma disease because there was some studies to suggest that people were finding it. The VA did an excellent, huge CSP, a cooperative study program study. Anyway, CSP study of one of the tetracyclines. And it was a very large, well-powered study. And basically, the study showed that the mycoplasma antigens didn't predict sickness, making them go away didn't predict health. That the tetracycline, which is also an anti-inflammatory, had some small benefit in inflammation, but not because it worked through a mycoplasma mechanism. Endocrine. Well, when the brain has neuroinflammation, you're going to see subtle, not in your face, endocrine problems, right? Because the HPA axis or the HPG or HPT axis is going to have a little trouble with fine tuning because of the neuroinflammation. So you're going to see sometimes abnormalities. And so actually don't get too comfortable when I've measured these as normal. I repeat these every few years and make sure they're not changing. Men in particular can really have terrible testosterone levels, and they can respond very nicely to treatment, to replacement treatment. So I keep an eye on that. Thyroid, because these people symptomatically look like a thyroid patient. They're profoundly fatigued and have a lot of the symptoms of hypothyroidism. You can measure it and say, oh, it's fine, and then get real comfortable. And then 5 years later, it's all out of whack. And you wonder, I wish I'd watched that everywhere. I wonder I didn't pick that up. So keep an eye on the thyroid. I was hoping that maybe just getting the sleep cycle fixed would be enough to restore the normal circadian axis for everything and get things to settle down. But actually, the data hasn't proven to be true. You do need to help sleep, but just helping sleep is not going to fix all the endocrine problems. Speaking of sleep, this is right off the VA webpage on Gulf War illness. I cut and paste it. I'm giving them their proper due. But it does show that there's been a lot of work on sleep in Gulf War illness. There's quite a few researchers doing this. And it showed first that Gulf War veterans are far more likely to have sleep apnea than an age-matched non-deployed veteran. So every Gulf War veteran deserves a sleep study, straight up. And you can help them. Another, it showed that while they may not have straight up sleep apnea in the classic sense, they often have upper airway resistance, where they're basically getting fatigued upper airway muscles, not quite to the level of apnea, but enough to cause a lot of snoring and a lot of sleep disruption. And one group did a lovely CPAP study in that group and did show benefit with CPAP. So a low threshold for using CPAP, if you're the sleep doctor assessing Gulf War veterans, to go ahead and give it a try. These people are sick, and if you can make them better with a CPAP in any level, if you give them 10 or 15 or 20% improvement, they're grateful for it. So it's certainly another thing that's not going to hurt them and could potentially really help them. So why not? And that's more or less what the webpage says too. So sleep, when you're treating them, you're going to reestablish the circadian rhythm as best you can. They often have horrible day-night cycling, going to bed at 3 in the morning and waking up at noon and having terrible normal circadian rhythm. Consider CPAP, like I say, with the low threshold. Conditioning them to have a normal bedtime, getting the screen time up, get people to stop using screens at bedtime, no iPads or books that are on screens or TVs in their rooms. They should use their bedroom for sleeping, and it should be like a conditioned Pavlovian response. I'm going to bed, it's bedtime. You can read a paperback book or listen to music or something, but you can't use light in your eyes. And then avoid the hypnotics that trap you in light stage sleep. And that's basically all the Valium derivative drugs, which unfortunately we use an awful lot for sleep. People tell you they have trouble sleeping, and if you don't ask the next question, tell me what you mean by that, you'll discover that they don't have insomnia. They're waking up in the middle of the night and they can't fall back asleep. And that's much more common in this population than not being able to fall asleep. But even when they can't fall asleep, you want to be careful that you're not trapping them in a poor quality sleep, an alpha wave sleep. So again, you're going to have a better luck with antihistamines or tricyclics. Doxepin's a nice drug for that. Mirtazapine, which is Remeron, the REM for that stands for REM sleep. It's a drug that induces REM sleep. That type of thing can be very helpful. So, so avoid the Valium derivatives and try these other types of drugs. If you have to be in Valium land, Ambien is the most sleep neutral of the Valium derivative drugs. Pain in sleep. One of the reasons people can't sleep is because it hurts. They're often in a lot of chronic pain. They lie down and they got a sore hip, a bad shoulder. They can't find a comfortable position and their pain's waking them up. And so pay attention to pain as the reason for their sleep disorder, and consider treating the fibromyalgia as a primary goal of helping them with their sleep if they have comorbid fibromyalgia. So fibromyalgia, as you know, is a hurts all over illness. It tends to hurt, and these are the physical exam tender point exams. When you're doing this exam, you just push until your thumbnail blanches. You should be able to have enough pressure that you get your blanch on your thumbnail, and that's enough to have done a tender point evaluation. And you literally go along pressing each of these points, and you count, and there's 18 of them. And the old-fashioned, and the way I still like it best, fibromyalgia exam said if you had 11 or more of these tender points, you had fibro. And that's something you can go back and check each time to see if they're getting better. So this pain cycle in fibromyalgia is not just a peripheral pain cycle, though it's interesting in fibro, a whole nother lecture that I got to make sure I don't overspeak on this one. A whole nother lecture is fibromyalgia, because there's now a lot of evidence that we've always said fibro is in your brain, it's pain signaling, right? And it's a hyper-reactive pain signaling area, and that is definitely true. When you've got chronic pain, you will upregulate the area of your brain that hears the pain signal. It'll literally grow. You'll have more capacity to hear pain and process pain signaling. And so that does happen in fibro. But there's now a pretty good evidence is maybe as many as half of the people with fibromyalgia have an autoimmune condition of their small fibers, a small fiber neuropathy of their sensory fibers. And that is diagnosed by a skin biopsy and sending the biopsy sample off to one of the specialty labs, like the one at Harvard, that is a small fiber neuropathy pathology expert laboratory. And there's a couple of other commercial ones. What's the name of the doctor up there? I just blocked her name, sorry. But anyway, it's not a bad idea to check out whether or not they have an autoimmune cause for their fibro, even though right now we don't have a guideline to treat it. The study that's underway is similar to ITP, a high-dose IV gamma globulin treatment to try to quiet down the autoantibody production that's causing this illness. But I'm going to focus on the brain for a moment and talk about the drugs that treat at the level of the brain. There are 3 approved drugs by the FDA for fibromyalgia that we borrow in Gulf War illness because of comorbid fibromyalgia. That is Lyrica, pregabalin, Cymbalta, duloxetine, and Savella, milnacipran. At the VA, we are supposed to go through one of the less expensive modalities like gabapentin before we move up to one of these more expensive ones, though now that these are now coming off of their patents, they actually are lightening these guidelines because Cymbalta in particular now is generic, and you can have that. I think pregabalin's come off as well. And so maybe these are not as big a deal. Nonetheless, gabapentin, as we're all comfortable with it, we know what its side effects are. You can try it and see if it's good enough. Then you can move up to one of these. When you look at these, remember one of the biggest problems we have with both Lyrica and Cymbalta, pregabalin and duloxetine is weight gain. Weight gain is a really big deal in these patients who aren't moving anyway. And if you can put 20, 30, 40 pounds on a patient by prescribing medications once in a while, so you really want to circle back really quick after you throw one of these drugs on board and make sure they're not putting on 3 or 4 pounds, and stop it quick if you're going to plow them down into a new comorbid diagnosis of diabetes because you added a weight gain drug. Sevella does not tend to, milnacipran, does not tend to have the weight gain. It does have nausea as a side effect, which is probably why not. So I'm not a big fan. I don't love any of these drugs. I'm just not a big fan. And that's why I like this one, low-dose naltrexone. Low-dose naltrexone is essentially a homeopathic dose of naltrexone, which we all know its cousin Narcan is an opiate, a drug that we use to reverse opiate overdose or use in opiate addiction. So the doses of the naltrexone at that type level are 50 to 100 milligrams, very high doses. Naltrexone at low dose is hitting a different receptor, and it's hitting it on the glial cell. Okay, we're working on glial activation with low dose naltrexone. The dose is 1 to 5 milligrams. I start at 1.5 milligrams for a month, and then 3 milligrams for a month, and then 4.5 milligrams for a month. That was the dose used in the fibromyalgia studies. And it was effective. The first study reduced pain by about 50%. The second study did too. It got a nice pain reduction, but in a lesser number. So they got about twice as high as placebo. I think placebo was 18%, and the naltrexone group was more like 40% of the patients responded. Nonetheless, it's so safe and so easy to use. And when it helps, it really helps. And it avoids using these drugs that I find as having a lot more side effects. So I press hard to be allowed to use naltrexone in my hospital, and I finally have won that argument. But I have to go through at least one of the other modalities and show that it failed before I'm allowed to go to a compounded drug. That's because the VA has a real thing about compounding. There was, a very bad thing going on with compounders about 15, 20 years ago, and a lot of regulations came into play, and the VA put some guidelines in. And so you really have to jump a lot of hoops to be allowed to use a drug that is not available from a pharmaceutical company at this dose, but it's easily compounded at this dose. My only cited thing on LDN in the VA, I hardly ever say this, even bother to say it in my private practice, but in my VA practice, it improves your sleep to the point that you dream more, you have more dream time, which is very healthy. But in patients with PTSD that are dreaming, it can be very alarming. So I usually warn people that if you get more vivid dreams for a few weeks, they go away. But if they don't go away, then just switch the medicine to the morning. Don't take it at bedtime. I prefer it at bedtime because it improves sleep, and sleep is a really big deal. But like I say, only in the PTSD patients, the patients that have more alarming dreams, do I worry very much that they're going to have more increased dreaming. We have a lot of drugs that do that. I don't know if you realize that, but the HIV world that I come from, we're constantly warning people about dreams. So there are a lot of other medications that we've had all along that do a lot of things and tick a lot of the buttons of things that we care about in Gulf War illness. These are all off, not clinical trials in Gulf War, but clinical trials in sleep or pain or migraine that are out there. And you can see that there are lots and lots of choices that you're very comfortable and familiar with that tick different columns here, like the tricyclics. But if you're going to use the tricyclics, really go low dose, like doxepin, which people tend to start at 25 milligrams. You can really make someone be if they don't have, anxiety and depression, and you start a dose like that, you're going to have a very sleepy patient. Starting at 5 milligrams, I even use the pediatric elixir. Comes in 10s and 25s. I'll have them take the 10 and break it in half. And take it for a few weeks that way, and then nudge it up if they need to, that kind of thing. So SSRIs, SNRIs I already talked about. NSRIs I already talked about. And then the anticonvulsants we talked a bit about. I didn't really talk about antipsychotics. There's a drug called Abilify that we're all familiar with that has suddenly become very popular in ME/CFS patients for the extreme patients that are housebound, bedbound, and anorexic. That seems to possibly have some efficacy. Again, not enough clinical trials, just case reports, but it's an interesting thing when you're really up against the wall and you have tried everything. That's interesting that Abilify, a drug that we really don't understand very well, actually helped those patients. Never forget the things that aren't drugs, though. I mean, we're here talking about drugs, but we have acupuncture, we have chiropractic and osteopathic manipulation. We have yoga clinics. We have ways to really help our patients in ways that don't involve medications. And I strongly recommend it can really make a difference. The patients appreciate anyone that can make them feel better, and they're willing to try. So, so partner up. I'm going to segue just briefly into some nutritional interventions. I always warn with nutritional interventions. Our patients look this up on their Google engines and they come in, overdosing, massive doses on supplements that are scary, like licorice root, which will knock the potassium right out of them, right? It's sort of like Florinef. It is the drug, it is actually what they extract Florinef from. So I told you, watch out for potassium. But this is, mystery dose Florinef. So be careful. There's supplements like St. John's wort that if you read about it, you'll realize that there's only one of the St. John's wort that has any medicinal effect, but there's 4 different plants and they're all out there on the market. How do you know if they're even taking it? Melatonin, very effective, but if you read I like to look at the websites that randomly draw things off the shelf and see what's in them. And boy, melatonin's all over the place. You'll see melatonin labeled at 2 milligrams with 20 milligrams, which is a very dangerous dose of melatonin. So you want really good sources, and the patients should, there's something called Consumer Labs. If you don't already have a $15 a year subscription to Consumer Labs, you can look up your drugs there and really get a lot of information about the quality of the product, particularly these over-the-counter things that our patients take lots and lots of. And then I tell my patients to hydrate. Next thing you know, they're drinking 2 gallons of water a day and they've knocked out their loops of Henle and they're dehydrated. And you're like, oh, geez. You come in with hyponatremia because they took your words and marked them times 100. So be careful. Now, there are some nutritional interventions that are being tested or have been tested. Anything to improve oxidative stress is a good idea. And there's a study that's coming out. It's not in the paper yet, but it's coming out from Dacoma Shungu at Cornell, where he used NAC, N-acetylcysteine, which is the precursor to glutathione, that crosses the blood-brain barrier, one of the few things that crosses the blood-brain barrier. And he was able to reverse in ME/CFS patients to normal using MRS spectroscopy, which is an amazing, cool tool to measure oxidative stress in the brain. He could take people from abnormal to normal with NAC. And then, so I like that one. CoQ10 doesn't cross the blood-brain barrier very well, but it's got all kinds of beneficial effects. And I'm the PI of a study that's just finished, and we're doing all the analyses. We missed our primary outcome variable. I know we're not going to see that, but we're doing the analyses now that looks to see if the level of CoQ10 and improving it helped our patients. I think we're going to find again that personalized medicine matters, and knowing what's wrong with people before you start supplementing them might be a good idea. And then you can see I'm not going to talk through the end of this slide because I'm talking too long. Vitamin D, shout out to people that like to give a lot of vitamin D to their patients. You want to keep their levels at an optimal level. The bottom of normal is not optimal. Low vitamin D causes neuroinflammation, and this is a neuroinflammatory disorder. So getting their levels up to 60, however you do that, and you know how you can do that. I already talked about omega-3. Taking B vitamins is a good idea, and the CoQ10 we talked about. The reconditioning thing I already spoke a lot about, going slowly, focus on flexibility, core, stretching, balance, give people lots of rest periods. If you're in rehab, don't put these through a classic cardiac rehab. They need to take breaks, lots and lots of breaks. Interval training is better to do 3 minutes at a time and then go back to resting pulse and then 3 minutes and resting pulse is a lot safer than trying to drive people up into a higher heart rate and sustain it, because they're just at their aerobic threshold when they're walking around. And if you push them over, they're going to have tremendous oxidative stress and they're not, don't have the reserves to clean it up. So I spend a lot of time getting their oxidative stress right before I even send them to rehab. And this is my slide. Hey, we're partners, and you need a patient that's thoroughly engaged in this. But so that you know, I got a couple more slides to follow to talk about the research. So you're not off the hook quite yet, but almost. But they're at high risk. Gulf War vets, just ask them, were you in the Gulf War? Because we forget to ask, and man, they have a lot of things going on. And like I say, there's 27 research studies going on. So we're doing a lot of work on, we have $28 million in Gulf War illness related research going on. We're the site that is the site for the National Gulf War Illness Clinical Trials Consortia, with lots of phase 1 and phase 2 studies going on around the countryside, as well as a whole bunch of independent studies we had even before we started the Gulf War Illness Consortium. And we're working at a lot of levels, things that can help people fix the oxidative stress response, things that we've done studies in the past in ME/CFS about CBT to show that reducing the stress response, like I say, your stress response can trigger relapses. So trying to help people with their stress and coping strategies and go through life a little more mellow is a good idea. What we've learned from research from the POM1 thing is that avoiding toxins is important. Mycotoxins in South Florida is a great big deal. People have had their houses damaged by hurricanes, and then they have molds in their houses. They don't even know that they're living in a mold toxic soup now. So you can have your house tested, and it's not too expensive to check and see if you're living in a mycotoxin house. I had my house tested. Oh my God, it was incredible. And my asthma completely resolved after I fixed the source of that. It was crazy to think that I'm an expert in toxins and I allowed that to happen. So imagine what our patients who aren't expert are willing to tolerate. This is another slide before I get to the research. Don't forget you got the war-related, down there in yellow, the risk centers. The risk is a virtual consultation. You can ask for it anytime you want. The war-related injury centers were set up for Gulf War illness, but now they do a lot of burn pit and other kinds of toxic exposures. Any toxic exposure, you can ask for a risk consultation. It's virtual. We live in the region that is coming out of Washington, D.C., so you'll get a consult out of the D.C. Risk Center. And they have a multi-interdisciplinary group. They do a deep dig into the chart and see what you already did. And then they'll come back and advise you what if any other workup you might need. Very, very helpful. But there's a lot you can do. The PCP can do so much of the whole thing. But you also have sleep clinic, rehab to help you, cardiology if you need a tilt or an autonomic dysfunction part. You can work up the endocrine system more completely. And you can take care of the comorbid PTSD, traumatic brain injuries, and so on. Our work shows that men and women are substantially different. Isn't that amazing that men and women are different? No, seriously, men and women are different. And you have to be careful when we learn something in men and we assume it's true in women, particularly with clinical interventions. And so we do a lot of modeling work in this illness, and it's very clear that our eventual treatments for Gulf War illness in men will need to be a little bit different for women, or maybe even a lot different as we go through these studies that we currently have underway. So to be careful with that. Women can, if they're acting the way they do in ME/CFS, and I think they are, go through menopause earlier. Of course, by now they're already in their late 40s, early 50s, so even older. So most of them are perimenopausal. But one of the things we see is that estrogen really matters to their health. And if you're thinking about using estrogen replacement, even though we don't have these studies done yet, the only window of time you have to use estrogen is immediately in the perimenopausal time. So you might be feeling, if their breast cancer risk is not too high, to lean into that a little bit. You might keep them from having Gulf War illness relapses as a result of going through menopause and having estrogen deficiencies. In our future studies, we'll glean this out better, but this is what we know so far. And this, as I was saying, our models just are totally different. And men actually do need that testosterone level to be normal in our models. And women also need that estrogen to be in normal in our models. So all these trials that we're designing now, we're trying to figure out how to do that. So where are we finding new interventions? Well, I've told you there's a lot of targets. There's bioenergetics, there's antiviral, there's neuroinflammation, pain, immune activation, adrenal, autonomic dysfunction, a lot of places to be here. So we use a homeostatic modeling to try to figure out, and we're actually in multiple places in some of our designs. We also have all these cool new tools and tricks to really dig into it. And that bottom one, computational biology, is what our group is. The reason why we're so well funded is because we're using supercomputers and all this amazing chaos theory to try to knit all those systems together and not do it one at a time, not say, oh, it's a mitochondrial problem or, oh, it's an immune problem, but to understand that everything leans on itself, that we're all very interactive. So we have a lot of trials underway. This one is just finishing. We still have a few spots left. It's a glutathione versus curcumin study, just about done. Very simple study, mostly virtual. If you have patients, we are desperate for study subjects. This one's looking at women again. We always need women and veterans with Gulf War illness. Oops, sorry. I'm not going to go back because I'm running out of time. But we always need women in our studies. This is our exciting study, and it's shocking how hard I'm having trouble recruiting this study. This is the one that results from all that computational biology we talked about, modeling this illness and trying to figure out if we could use the computer to tell us what the right treatment should be, and go beyond that, ask the computer, could we actually reboot all these homeostatic networks back to normal? Is it possible using a computer design to say, if we're not just pushing one button, we're pushing 2 or 3 buttons in the right order, could you shove the immune, the endocrine, the autonomic in a direction that shoves it all the way back up over a mountain of homeostatic balance into a new homeostatic balance that is healthy? So we're desperately seeking 17 more recruits into this study so that we can move on to phase 2. But this is the only study I've ever been able to design in Gulf War that has the potential to actually cure rather than treat the illness. And so if you have patients, honestly, we are very keen to find people for this study. As I say, this is the homeostatic balance where we're trying to not ignore any of the data. It's all in the model. And then we have this design where you can see the little red circles there. That's your balance of how all these networks are down in that little valley there. And normally if you get sick with something, you kind of crawl up the mountainside, but you always roll back into the valley. And our thought with Gulf War illness is you climbed over the mountain, fell into the next valley. And now there's a mountain between you and being healthy. So the computer designed all these different strategies to try to force you out of the balance that you were in, the homeostatic pit down there that you were, and back over the mountain into the normal space. That's the idea. So the computer ran hundreds of thousands of clinical trials and gave us a design, which we put into play in the mouse model that we have for Gulf War, and we cured the mice. So we were very excited that the computer predicted correctly a strategy that actually could cure a chronic mouse illness that's, from a organophosphate exposure mouse that we use for the Gulf War illness model. And then we moved it to human, and that's what we're doing right now in phase 1. This is, supercomputers giving us our designs. Pretty cool. We're excited about this. So that's where we are with that study design right now, is we got all this from putting people on the bike and getting all this data under the challenge of exercise. So we basically draw the bloods 9 times over 24 hours to see what happens, to figure out what the mediators of relapse are, and then put that all into the computer, get a design, tried it in the mouse, cured the mouse, and now we're going for the human. We also have a study that's about to start recruiting. It's really late. We had to wait because of the pandemic, but this is for going after the autoimmune group of Gulf War patients who have discovered an autoantibody in the brain that's affecting the brain, that's causing inflammation in the brain. And so this one is trying to quiet antibody production so that we can reduce autoimmunity. And that's a different study. And this is our consortia, the Gulf War Illness Clinical Trials and Interventions Consortia. It's a great big consortia with 6 total sites and 4 VAs. And a very exciting study with 4 different phase 1 and phase 2 studies, 6 now. It's an umbrella that covers a lot of different types of studies, and your veterans are going to be getting letters from us or emails as they're coming along if we know that they exist. But like I say, it's hard to figure out who has Gulf War illness since we don't have an ICD-10 code. We can't just find them using Vinci or something. We have to go out there and use social media to hunt for them. We also have a number of other studies going on. So you can see I have something 9 or 10 studies. So bottom line, we're desperate. And if anybody, this is so important, if anybody in your patient population is interested in our studies, this is the person to contact. Zach Barnes is our lead recruiter. Zachary Barnes, Zachary.Barnes at va.gov. And if you could let your patients know about us, we would be so grateful. Thank you very much.